Good morning, everyone. Thank you for joining this session. It's really good to have so many people joining the conference today. My name's Jean Ledger. I'm a Senior Research Fellow at University College London, and I'm chairing this session today on how is evaluation helping to inform the NHS recovery. This is just an introduction to encourage you to engage in this session by posting questions in the chat, and we have two fantastic speakers. We have Angus Ramsey, Senior Research Fellow from University College London, and Geraldine Clark, Principal Data Analyst from the Health Foundation. We will have about 15 minutes for our speaker presentations today. You can post questions in the box that you see on your screens, and it would really help if you could indicate which speaker your question is for today. We will be monitoring the questions as they're coming in, and we'll have about 5 minutes at the end of each presentation to ask our speakers the questions that you sent in. So we're focusing on the role of digital technology and evaluations during recovery. And I'm going to hand over to Dr. Angus Ramsey, who's going to be talking about the NIHR Reset Rapid Evaluation of pre-hospital triage for suspected stroke patients. So I will hand over to Angus now. Thank you very much, Angus.
Thanks very much, Jean, and hello everyone. Yes, as Jean said, I'm Angus Ramsey, and I'm going to give an overview of our evaluation of pre-hospital video triage for suspected stroke patients. So just a bit of background. So evidence suggests that stroke patients who are treated in a specialist stroke unit are more likely to get the right care at the right time and have better long-term outcomes, such as disability, in terms of disability, independence, and mortality. However, the tools that are available to screen for stroke, for example, the FAST screening tool, are pretty over-inclusive. They tend to identify lots of potential stroke patients who turn out not to have had one. And these patients still often tend to get taken to stroke units. Under normal circumstances, this has a number of implications. So, for example, many non-stroke patients don't necessarily get the right care as soon as they might do, for instance, because they've bypassed their local hospital to get to a stroke unit. And it also puts additional pressure on stroke services because they have to take care of non-stroke patients as well as the stroke patients. Now, during the pandemic, over the last couple of years, additional concerns arose about vulnerable patients making unnecessary journeys to stroke units and either catching or spreading COVID-19 to patients around them. And in response to these rather pressing concerns, really serious concerns, ambulance and stroke clinicians in North Central London and East Kent introduced pre-hospital video triage for suspected stroke patients in the spring of 2020. So this just is a little schematic summarising how it worked very simply. The pre-hospital video triage services let ambulance and stroke clinicians communicate using their iPads and FaceTime so that stroke clinicians could assess suspected stroke patients while they were still on site, so where the stroke had happened. It was hoped that this would result in patients being more likely to be taken to the right service and reduce unnecessary pressure on stroke services and reduce risks of unnecessary spread of COVID-19. So a couple of details of the evaluation. This is our team, and as you can see, it brings together a nice combination of researchers, clinicians, and patient representatives. Our evaluation ran from July 2020 to September 21, when we submitted our final report. And in research terms, as people are probably aware, this is pretty quick, especially given that we had to pause data collection for about 3 months, around about this time last year when COVID was really putting a lot of pressure on services. So we had a number of questions in our evaluation, including what the evidence base was for pre-hospital video triage for stroke, what the perceived acceptability, usability and safety of pre-hospital video triage was in North Central London and East Kent. We were interested to know whether these services supported appropriate, safe and timely conveyance and treatment of stroke patients. And we were interested to learn about which factors played a part in implementation and impact of these services. Finally, we wanted to look at which aspects of these services could be retained post-COVID-19. So to address these questions, we conducted used a number of different methods, including rapid literature reviews, qualitative analysis of interviews, observations and documents, quantitative analysis of ambulance conveyance data and stroke clinical intervention data, and we conducted a survey of ambulance clinicians, focusing on both North Central London and East Kent. I'll now run through some of our key findings. We're going to be focusing today on the qualitative analysis, the survey, and the quantitative analyses. So we're not going to talk about lit reviews today. So to understand what clinicians thought about pre-hospital video triage in North Central London and East Kent, we interviewed 27 ambulance and stroke clinicians. We conducted observations of 12 events, for example, governance meetings, training sessions. We analysed 23 documents, including meeting minutes and patient pathways. And in our survey, we got data from 233 ambulance clinicians across North Central London and East Kent. Our analyses found that clinicians in both North Central London and East Kent viewed pre-hospital triage as highly usable, though North Central London ambulance respondents seemed generally more positive than their colleagues in East Kent. Important supports of usability included having a stable network and audio-visual signal, and ambulance clinicians in both areas described sort of backup processes for when these systems failed, so most commonly reverting to traditional conveyance decision-making processes. In both areas, we found that training was very important. It helped ambulance clinicians feel confident with using pre-hospital triage. Our respondents indicated that they preferred active training, such as demonstrations and run-throughs, whether in person or online, which tended to be used in North Central London. A more passive approach or less active approach was used in East Kent. Clinicians in both areas found pre-hospital video triage acceptable, and they preferred it to what had happened in the past, sort of business as usual, and they wanted it to continue. Again, in our survey, we found this was more pronounced in North Central London than in East Kent. Ambulance clinicians described how the pre-hospital triage process increased their confidence in their conveyance decisions. They found that the specialist input from the stroke clinicians provided a degree of reassurance. Stroke clinicians, on the other hand, they were very positive about the service, and they felt it felt quite natural, and it was nice to be reaching into an earlier stage of the care pathway. But they did raise concerns about performing triage assessments alongside their everyday duties. They found that this placed just created additional work and additional pressure and strain on attention and so on. Implementation was supported through a number of factors operating at different levels, sort of national through down to local. In terms of the wider context, COVID-19 created what's commonly termed a sort of burning platform to change. There was clearly a problem that had to get addressed. Locally, this prompted adaptation of management and governance processes to be more supportive and enabling of innovation. So proposals to change were processed more quickly, for example. Clinical leaders in stroke and ambulance services engaged actively to develop and implement the new services, working across their organisational boundaries, both within their host organisation, up and down with senior management and frontline staff, but also working out across towards different organisations, including the wider governance system and working between stroke and ambulance services. Finally, we found that the innovation itself fitted well with professional values, especially in terms of the prioritisation of delivering appropriate high-quality care, which both ambulance and stroke clinicians indicated they felt was under threat at the time of the pandemic. Turning to impact on conveyance and care, to understand the impact on patient conveyance, we analysed local ambulance journey data for about 1,400 patient journeys where pre-hospital triage was used. And looking at those data, we found that approximately 53% of suspected strokes in north central London and 42% in East Kent were not transferred to a stroke unit. Local audit data and our observations of meetings where these data were reviewed suggested that there were very few cases where stroke patients were not transferred to a stroke unit, which overall together suggests that many stroke patients were now avoiding unnecessary transfer to stroke units. We found that over 95% of patients, and all patients in East Kent, were transferred from scene of stroke to hospital within recommended journey time thresholds. And we looked at national stroke audit data, which indicated no evidence of increased time from stroke symptom onset to arrival at hospital or the stroke unit. We next looked at delivery of stroke clinical interventions, for example, timely brain scans and clot-busting therapy if appropriate. Looking at the national audit data at team level for almost 140,000 stroke patients submitted between 2018 and 2020, we found that following introduction of pre-hospital triage, the services in London and East Kent either performed better than or not significantly differently from services elsewhere in the country. However, we must note that some of the improvements that we observed may have been due to other service reorganisations that took place at the same time, so sort of moving around of stroke units and so on. So just to conclude, we found that the services introduced in North Central London and East Kent were seen as usable, acceptable and safe. Especially important was the stability of network and audiovisual signal. Several factors, including national and local context and leadership and implementation approaches, influenced delivery of the new services. Active training approaches, whether online or in person, were preferred by ambulance clinicians, while the impact of triage assessments on stroke clinician workload was seen as an important risk to sustainability. We saw several limitations. We had several limitations in our work. We couldn't interview stroke and non-stroke patients or carers, and we couldn't speak with a range of other stakeholders, including nurses, managers, and the wider sort of local system governance systems. Our ambulance conveyance data had no historical or regional comparators. This meant that we couldn't assess with confidence the actual, what difference pre-hospital triage made to conveyance times. The national audit data, the stroke audit data, were aggregated at team level, so it wasn't at patient level, and so we weren't able to analyse quite as deeply as we'd want to the extent to which pre-hospital triage impacted on quality and safety. And finally, our survey used a convenience sample. So while we did only survey people who had used the triage services, we had no control over which clinicians decided to take part. And to address several of these limitations, I and my colleagues are really excited to have recently commenced a new research project, which has been funded by the NIHR Health and Social Care Delivery Research Programme. Photonic is a mixed method study running from 2021 to 2023, which will analyse implementation and impact of pre-hospital video triage for suspected stroke in North Central London, East Kent, Darrant Valley and Maidstone. We're going to get perspectives from a wider range of stakeholders, including stroke and non-stroke patients and carers, wider group of staff, and indeed the wider governance systems, much wider range of stakeholders. We're going to be able to use patient-level data with national controls in order to understand the impact of pre-hospital triage on patient conveyance, care delivery, outcomes, and value for money. And through this, we'll hopefully be able to provide lots of additional lessons for further implementation of pre-hospital video triage, both in stroke and other settings. And just this is a reference for our final report, which is in press. And so these findings are hopefully going to be in the public domain very soon. Just like to thank everyone who took the time to support this work, both by participating and by guiding the research, the evaluation, and just the standard disclaimer that this research was funded through the NIHR RESET program. And I think that's all I've got. So if people have questions now or afterwards, thank you.
Thank you so much. So please post questions for Dr. Angus Ramsey in the chat. This is such an interesting study, Angus, and I was really fortunate to be part of the wider team as well. And we have a couple of questions already that have come in. One of the ones is, have we found any differences in usability by patient type, particularly disadvantaged groups? I'm aware that's a tricky one to have answered in a rapid evaluation, so we may need to reflect on that for the future study and work.
Do you want me to address it just now, Jean?
Yes, please. So any difference in usability by patient type, particularly disadvantaged groups?
It's something that we couldn't look at, but it is something that that sort of came up in discussions with ambulance clinicians. And I think an important point that we're still to research properly, formally, is the extent to which there's an impact of, whether socioeconomic background or cultural background on the effectiveness of communication across these systems. But certainly the view from ambulance clinicians was that it wasn't necessarily impacting, because the ambulance clinicians themselves very often are the key ingredient in bridging those sorts of gaps, the communication gaps and so on. But it's something that we will have to investigate further with photonic.
Thank you. Another question is about, did you provide any formative learning, rapid real-time learning during the study, or was it all at the end?
I mean, this was a rapid and formative evaluation. Several of our collaborators were actual members of the team, so they were in discussions regularly about the project. But we also attended sort of regional governance meetings and had dedicated interim feedback events where we shared progress of the work and interim findings. And this information was seen as being quite helpful for the local collaborators in providing wider assurance to their local stakeholders about how their projects were progressing. So yes, we were formative, and it did seem to be helpful in both directions.
I mean, it's very much a collaborative piece of work, and I think there's reflections, aren't there, on how closely you need to work with people at pace and share formative learning on these rapid evaluations. Angus, there's a question about comparators, and where will your comparative data come from in the photonic study? Are you prospectively collecting the baseline ambulance data?
So with research of this kind, what we generally do is make use of established routinely collected data sets. So we've worked closely with ambulance service collaborators, both in the London and Kent areas, but also with national leads to establish which data sets on ambulance conveyance are available. And we have spoken with a number of ambulance trusts to confirm their agreement to share their sort of patient level data with appropriate checks and permissions. So basically, these are data that are being collected on a regular basis for every single patient, and to a very high standard, and have been for several years. So we're just requesting data that are already being collected.
Thanks, Angus. A couple more questions I think we have time for. One is about qualitative research being key here for this type of evaluations. Do we find that quantitative research and findings are preferred by journals? Is this a problem? Do you have any comments on that?
I think certainly with publishing in any journal, one tends to target what that journal prioritizes, and I think some journals certainly prioritize quantitative work, but there are a lot of journals that are interested in how change works and how implementation works, and which really value qualitative approaches. And we've been the work that we've done in stroke and other settings over many years evidences how much potential there is to publish both qualitative and mixed method research, demonstrating not just whether something makes a difference, but very importantly how. And something that I've found sort of through, working on formative research over the last several years, the appetite amongst clinicians and service leaders for those qualitative sides of things is really striking. So I think there's a genuine appetite there, and our experiences of publishing and collaborating to mobilize knowledge in a more direct way really evidences a strong appetite for qualitative research in healthcare and social care.
Thank you, Angus. And just one final question I think we have time for. Given the theme of this session, what do you think the potential for this particular service innovation is for recovery and NHS recovery, thinking forwards?
I think there is significant potential in the sense that in discussions, particularly in discussions with ambulance services, there is a real desire to get people to the right place first time. It's seen as being a major issue just now, involving sort of secondary transfers and additional journeys, and so it's seen to take up a substantial proportion of ambulance services time. Having systems that minimize the need for additional journeys, secondary transfers that aren't warranted by a changing condition, I think would represent a huge, and certainly the impression I get from ambulance services would represent a huge boon in freeing up what are very limited and valuable resources. So I think that would be one of the main benefits. I think the broader point is that it's a real opportunity for innovations like this represent a real opportunity for health services to take a genuine step forward from where they were before the pandemic, where things like a 20% false positive rate in stroke units was considered just par for the course. It's something that people can now avoid and lead to having services that are genuinely much more tailored to the needs of the patient.
Thank you so much, Angus. It's a really interesting study, and it's an example of where rapid evaluation conducted during COVID is now leading to an additional study to address some of the limitations as well. So more to follow on this really exciting service innovation. I'm afraid we don't have time for any more questions. So just a big thank you, Angus, to you and colleagues for that really interesting work. And we will now hand over to Dr. Geraldine Clark, who's going to present on bringing together routine public and private data to evaluate the impact of digital first primary care. Dr. Geraldine Clark is at the Health Foundation, where she's principal data analyst and has been looking at digital first primary care. So over to you, Geraldine. We're really looking forward to your presentation.
Thanks very much, Jean. So I was going to talk to you about a programme of work that we have that tries to bring together routine public and private data to evaluate the impact of digital first primary care. So just a quick overview of that, and then I'll sort of delve into one of the more recent evaluations that we've been doing. So first of all, you might ask, what is digital first primary care? So this is where a patient's first point of contact with a GP is via digital or online tool. So they access the practice to get advice, book an appointment, request a prescription or referral via an online consultation system. But they can also have their care delivered with a healthcare professional via telephone, online, message or video. So digital first primary care was established as a national priority in the long-term plan in February 2019, with the aim of improving access to general practice and helping to manage workload pressures on GPs. The 2019 GMS contract set out a requirement for all GP practices to offer online consultations by April 2020 and video by April 2021. So of course, this was further accelerated at the start of the pandemic in March 2020, when all practices were urged to adopt total triage and to deliver consultations remotely where appropriate in order to reduce the risk of infection to patients and staff. So now more than 80%, possibly more, of practices are equipped to deliver digital first primary care, and most GPs agree that digital technology should be retained in the long term. But this has all been implemented against the backdrop of unprecedented demand, increasing risks of preventable disease, people living longer with multiple conditions, GPs now having to offer a wider range of services, shortage of GPs, and these are all compounding the pressure. During the pandemic, GP consultations fell to an all-time low, now resulting in a severe backlog of care that needs to be addressed, further creating additional pressures on secondary care services. So what are the impacts on patients, workforce and the wider system of digital first primary care, and how has that changed pre and post-COVID? So we have a programme of work at the Improvement Analytics Unit looking at the impacts of this. First of all, we're collaborating closely with NHS England, the online consultations primary care group, and trying to deliver relevant evaluations which can be ultimately used to inform NHS policy and strategy. So we focus on the quantitative side of things, but then we're also collaborating with qualitative and academic partners to explore and interpret our findings. So first of all, some of the data sources that we've established. We've built up good relationships with a number of private providers of online consultation systems, and quite excitingly, we now have data from these providers on patient-level requests for primary care, representing more than 50% of UK practices, and across a number of years. So, and each of these data sets is very rich, offering different and great opportunities to explore the characteristics of patients, how they access general practice, as well as how that care is delivered. So as well as looking at that provider data in isolation, we want to link it to routine data sets in order to examine the wider impacts. And ideally, of course, we do this at patient level, but due to data constraints and issues of anonymity, we typically have to aggregate and link this data to routine data sets at the practice level instead. So one way we've done that is just simply aggregate counts of the patient requests. And this is providing us with, if you like, a kind of proxy measure of practice digitalization. And then we'd link that to routine data. So planned program of work using these data sources, we've got a variety of evaluations in train. So first of all, using the linked data, we can look at what's the impact of practice digitalization on emergency care. So, you know, how's that affecting people turning up at the A&E or seeking, you know, an emergency admissions for care that perhaps could have been better managed in general practice. Also looking at how that affects patient experience and satisfaction using the GP patient survey, and then looking at patients' reason for consulting and clinical outcomes in the CPRD data. We've published some short reports on some of these, looking at the impact of practice digitalization, but that's typically just using the first Ask My GP practices, which are only about 200, but now, as I say, we've got more than 4,000, so we'll be updating those reports. And we also plan to use the unlinked routine data to look at impacts of remote consultation on prescribing and continuity of care. But of course, then we can also delve deeper into the supplier data itself to tell us what it can tell us about what factors are influencing demand, access and delivery of primary care. And that's the work that I'm going to focus on today. So here we're going to present results that are delving deep into the Ask My GP data that we have. So this is patient level data of all requests for primary care. Flooding into these practices between March 2019 to September 2021, and we want to look at what this can tell us about what factors are influencing demand for care, so what types of patients are asking for care at these practices, and then what are the characteristics of patients who prefer to access online versus telephone, and then finally what influences how a GP delivers that care. So first of all, a little bit about the data itself. So Ask My GP is one of 31 online consultation systems that's currently approved for use by NHS Digital, and it's in use by, at the last count, by about 216 practices across the UK. So the way it works is patients initiate their request for care via a link at the practice website. They're presented with a short questionnaire-based form and can report their symptoms using free text. Those patients who prefer to use the telephone can call the practice, and staff will complete the form for them. These requests are then forwarded to administrative or clinical staff at the practice, who triage the request and arrange for care to be delivered in the appropriate mode. So remotely, either by telephone, SMS message or video, or face-to-face in the practice at home. So this is a very rich data set that's allowing for an examination of novel combinations of factors, as well as, of course, the GP practice ID. We know how old, we know the sex of these patients, what time they were asking for care, and how they access that care. So what did they go online? Did they access by telephone? Were they a patient or a proxy? What they were, how they labeled the problem. Did they label the problem as an existing medical problem, a new medical problem, a medication query, or some other kind of problem? And then also, quite interestingly, how they wanted that consultation to be delivered. So would they prefer an SMS message, telephone call, a face-to-face appointment? And finally, there's also some information about continuity of care, whether that patient would like to see a particular GP. So first of all, a little about the GP practices. We narrowed it down to 146, so we could tell we're using it for all incoming requests. We wanted to make sure that we were capturing practices that were recording the ones that were coming in by telephone. And so that comprised 42 that were using it before COVID, and then 104 that came on board during the pandemic, covering 28 CCGs, and broadly representative of practice in England, but with slightly larger white ethnicity, slightly larger list sizes, and less deprived patients and more living in rural areas. But a similar proportion of patients stating good or very good overall experience in the 2020 and 2021 GP patient surveys. So first of all, we looked at what factors influence patient demand for primary care. And the first thing we did was just to simply calculate the total request rates per person patient year across 3 periods. So we looked at the year before COVID and each of the first 2 years of the pandemic for which we had data. And so this table is summarizing our findings. So you can see here, for example, that females are consistently demanding care at a slightly greater rate than males. So we've got 4.4 requests per person patient year in the most recent period, March 21 to September 21, compared to 2.7 requests from males. Age rates are consistently J-shaped, so they're quite high in the 0 to 4-year-olds, dipping to very lowest rates in the 5 to 14, but then rising to the very highest in the oldest patients, those over 75 years. So during this time, the demand for care has increased by 24.2%. So that's comparing the most recent period with the pre-pandemic year. And females are accounting for a slightly larger share of that increase than males, so 16.5% versus 13% in the first year of the pandemic, and 24.8 versus 23.8% in the second year. Rates in patients aged over 45 years have increased more than rates in younger patients. So you can see, for example, that the over 75 had an increase of 36.6% in 2021 compared to the year before COVID, but substantial decreases in younger patients during the first year, so up to 23.2% in those aged 0 to 4, have recovered pre-pandemic, so that overall there's only a small change or a non-negligible change of 2.3%. So first of all, we looked at the proportion of demand for care split by request and user types. So the top figure there on the right shows the proportion of care according to how patients class their problem. And the grey, which may not be clear on here, is the 3 national lockdowns. I'm afraid that hasn't come out on this slide. But as you can see from this, the most requests are about existing medical problems. So that's the red line, reckoning over about 40% of the requests. And you can see that the proportion of requests about new medical problems is increased after the 3rd lockdown. That's the green line, slight increase there. The bottom figure is now splitting the proportion of requests according to whether a patient's a frequent attender or not. So we defined a patient as a frequent attender if the number of requests over the study period was in the top 5% for their age and sex at that practice. And rather surprisingly, you can see that more than 40% of requests consistently from the frequent attenders. That's the green line in the plot. But equally, we can see an interesting increase here during 2021 from non-frequent attenders. So just quickly, some conclusions that we made from that. So it's reassuring that these patterns and volumes by age and sex are consistent with that reported in a 2016 landmark paper by Hobbs, possibly just to help us assure us that we're capturing the demand for care at these practices, and maybe providing some signs of robustness and potential generalizability of results. But interestingly, a small group of patients, the frequent attenders, and requests about existing medical problems are accounting for a large proportion of the demand. So one conclusion there might be that although many of these patients have complex needs and need to be seen regularly, and understanding who these patients are and why they're seeking care might help general practice provide services more effectively. For example, research indicates that frequent attenders may have wider psychological and social issues that may be better supported in a non-medical environment. And finally, a steady increase in the proportion of requests from non-frequent attenders and for requests about new medical problems throughout 2021, as well as that recovery in the rate of requests from younger patients, are consistent with pent-up demand due to missed or delayed diagnosis, suggesting that these patients are what's making up the care backlog that's driving demand in 2021. So I'll just move on quickly. So the next question we looked at was what factors influence how a patient is accessing primary care. So we looked at the proportion of care according to how patients are choosing to access the practice, so online versus telephone, and then how they ask for that care to be delivered, face-to-face or remotely, either by telephone, video, or SMS message. And just some brief observations there. Looking at the top plot, we can see that most requests here are initiated online rather than by telephone at these practices, so that's the blue line. But also, we've found separately that once patients tried the online system, they're more likely to do so next time. And then in terms of how patients want their care to be delivered, we see that telephone's the most popular requested mode, that's the green line. And you can see that requests for care dropped off during the pandemic, as has been widely reported, as patients responded to guidance and need to avoid risk of infection. But contrary to reports, only 10% of the patients of these practices are asking for face-to-face in September 2021. So the next thing we did was look at an association. So we did ran a regression model here to look at the association between the different patient characteristics and how they choose to access. So we ran separate regressions in each of the 3 periods, the year before and then the first 2 years of the pandemic. And these are the results of that. So here we've got the forest plot, and the values to the left of the dashed line, which represents an odds ratio of 1, indicate the characteristics of patients who prefer to access by telephone, and to the right indicates those preferring the online route. So we can see here that males, non-frequent attenders, and those asking about medical problems and other questions, those who want a face-to-face consultation or continuity of care, were consistently more likely to contact the practice by telephone rather than online compared to the relevant reference group. So some conclusions there. We observed an increasing ratio of requests that were made online versus telephone, but that wasn't tracking with the increased demand. So that suggests to us that there's been a shift in patient communication preference rather than an increase in demand due to the expanded access that online offers. But this is contrary, of course, to anecdotal reports that increased demand is what's causing it is a result of expanded access. But of course, this is only one model, so we would need to make comparisons with alternative online consultation models. It seems that patients with these practices like accessing online, suggesting they're comfortable with digitally enabled healthcare. But of course, we also found that how a patient contacts the practice depends on their characteristics, preferences, and needs, suggesting that hybrid models are essential to ensure that selected patient groups are not disadvantaged. So just quickly, because I'm running out of time, but the final question we looked at was what factors influence how a patient is accessing primary care. So here we've split the demand according to how the care was actually delivered. So again, here's one of these plots, pre-pandemic, you can see that approximately 40% of requests were delivered face-to-face. That's the red line there. During the pandemic, this dropped massively, but only recovered even in September 21. It's only 14% of care has been delivered that way at these practices, and in fact, only 10 of 146 delivered more than 20% face-to-face in 2021. Telephone was most popular during the pandemic, and in these practices, video was seldom used. So again, we also modeled the request characteristics according to the association between request characteristics and delivery mode. So again, to the left of the odds ratio line, the dashed line of 1 indicates patients who prefer to have their care delivered by face-to-face, and the dots to the left indicate the characteristics of patients who prefer to have their care delivered remotely. So compared to the reference groups, face-to-face consultations are more likely to be used by clinicians than remote for consulting with either the very young or the very old, for new medical problems, for non-frequent attenders, for those who access by telephone, for those who ask for a face-to-face consultation, and for those who are seeking continuity of care. So finally, what did that conclusions that we have from that? So we see again that patterns of care delivery were tailored according to clinical need and patient preference, specifically in a manner that is consistent with good clinical care. Specifically, it seems that face-to-face care prioritized for those who requested it, who had the most complex needs, and remote consultations prioritized for frequent attenders, patients consulting about existing problems. These are patients less likely to require an examination, more likely to be known to their GP with a pre-existing doctor-patient relationship. And combined perhaps with a positive GP patient survey overall experience scores, suggest that remote delivery of care can be an important and effective tool in managing GP workload. But as more work is required, of course, to examine exactly how the mode of care delivery does relate to a good clinical outcome. Contrary to the prevailing media narrative, only a minority of requests stated a preference for a face-to-face. And of course, well, remote consultations might be preferable to office visits for many patients, likely as a result of great convenience and reduced travel time. And then finally, the NHS 2021 NHS support plan set out a concern that practices offering less than 20% of GP appointments face-to-face would be wholly inappropriate and likely to be contrary to good clinical practice, and set out potential contractual targets for the proportion of appointments that should be carried out face-to-face. Our work might suggest that the imposition of such crude numerical targets would be inappropriate. In our work, 128 of the 146 practices would have fallen foul of such a threshold between March and September 21, and hence have been threatened with reduced funding, despite some evidence here suggesting that care was consistent with good clinical practice and in tune with patient preference. We would advocate that key factors in determining the appropriate mix are likely to include the age, frequency of use, clinical need, and patient preference. So just a few strengths and limitations. So this data does allow a novel exploration of how combinations of patient characteristics, preferences, and need influence care access and delivery in English general practice. We can follow a patient's journey right from access through to delivery and use this flow of information to understand how all these factors interact. And we're not aware of any other work that examines this sort of combination of factors in general practice. Unfortunately, these practices are only broadly representative, and so the results are not necessarily generalizable. It's only a single supplier, and of course wouldn't be generalizable to other suppliers. because how a practice implements it and the particular model will have a strong impact on patient behaviour. More work is, we weren't able to examine trends across different socioeconomic and ethnic groups, so we didn't have access to that information, so more work is required to look at those impacts. And finally, just some acknowledging, this is a detailed work from Alison Diaz, myself, Richard Bryan, Emma Westerson, on Walters, and of course the members of the team at the Health Foundation and at the NHS team that have been supporting us in this work as well. Thank you.
Thank you, Geraldine. Brilliant, and so much rich data there. We've got quite a few questions really about data, and some of them you may not be able to answer, and I know this work's ongoing. But just, there was one question about how do you know, or do you know how satisfied patients were with this service? You know, it's one supplier, but I wonder if you could maybe say something about how you're analysing that. I know you've got the GP survey data as well. How do we begin to think about patient satisfaction with these services?
Well, of course, we've taken one of the questions from the GP patient survey and seen how these practices, how patients with these practices have responded, and compared that to national. And as I mentioned, they are, certainly well within the range of national. So there's no evidence there to support that. But of course, we do also from Ask My GP have access to the friends and family and the surveys that were sent out after patients had their appointments. But this was difficult to sort of analyse during COVID because, of course, everybody was happy with their GP practice during COVID. So we haven't looked at that, but we are working with qualitative partners. Brace in particular identified a number of these GP practices that are going to go and talk to in more detailed interviews patients and staff at those practices to sort of try and evaluate and get to understand that a bit more.
Thank you. And in terms of workforce, do you have any observations or conclusions from the analysis you've done about impact on workforce, or is it too early to say?
I think it's too early to say on that. Again, I mean, I think what the qualitative partner will speak to the workforce about how they feel about it. But the only we can see that we take some, maybe we take our message from the fact that the GPs were tailoring the care according to patient needs and preference, which may have helped with workload. But yeah, no, we don't have any workload statistics, and we don't have the length of time that these consultations took to evaluate those kind of pressures.
Thank you so much. So I think we've probably got time for one very quick question, Geraldine. Just somebody saying, great project, thanks for sharing. Can I ask, with linkage at practice level, and how are you planning to interpret results from the analysis, looking at reasons for consulting and clinical outcomes? Do you have a hypothesis?
Well, that's a separate evaluation where we'd be using the rates that we get from Ask My GP practices and all the other providers to see whether or not that's affecting what kinds of questions patients are asking for. So I suppose one hypothesis might be that there's more administrative requests coming into the practice. That would be something that we're looking at. Perhaps the rate of referrals is different at these practices, and also how the care is delivered. Maybe there's a different distribution of how the care is delivered across different healthcare professionals at the practice. So yeah, so quite a lot of things we need to be careful and sort of outline what the exact evaluation, because there's a tendency here there's so much rich data, there's a tendency to try and explore too much stuff. We need to try and be focused.
And I'm told we have 1 minute for one final questions. I mean, about the outcomes being different between rural and urban environments. Do you have any observations around differences around urban and rural contexts at this stage?
Well, our practice comprised more patients that were living in rural areas. I think we've got any observation about that, but we've now got data, as I said, from many more suppliers, so we would we'll use that to try and explore that question in more detail.
Brilliant. So I'm afraid we're out of time. Just a couple of final things to wrap up. First of all, big thank you to Dr. Angus Ramsey and Dr. Geraldine Clark. Their fascinating presentations today. I hear that Angus is very happy to respond to some questions that we didn't have time to put forward to him today. So we will try and follow up with people who've posed questions that have not been answered within the session. And now I'll just briefly hand over to Anna to wrap up. So thank you.
Yes, thanks very much, Jean. We've come to the end of the first day of the conference. I think there was some brilliant content being shared throughout this morning. I think in particular it was really great to hear this morning about some real-world examples that demonstrate that it is possible to overcome some of the key challenges that we typically face when implementing or spreading the use of digital technologies or AI. We've also just heard from 2 evaluators sort of demonstrating their analysis and how they try to inform ongoing service changes that will be key in sort of shaping the NHS recovery going forward. So I'm not going to try and summarize those presentations in one line. If you've missed them and you'd like to go back to them and have a look, they will be made available on demand on this platform. So you can go back and watch the individual presentations if you like. What I will attempt is to try and summarize the conversations in the various breakout rooms. So behind the scenes, the moderators in each of the rooms have been busy scribbling a few notes down and send them to me. So I'll see if I can do them justice. I've tried to order them in a way that seemed to make sense to me. I think Steve very kindly sort of explained some of the challenges, particularly around sample size issues and sort of limitations in what quantitative analysis might do when you sort of look at the intersectionality of various aspects of health inequality. I think some of the groups sort of comment on that as well. Sort of that will remain a challenge. However, they also feel quite strongly, I think, there's quite a lot to be gained by getting the basics right to begin with. So maybe we can look at individual elements of inequality to begin with and sort of improve practice there. There was very widespread recognition across all the breakout groups that there's a very important role for both qualitative and quantitative evaluation. I think there's sometimes a tendency to sort of look at the numbers specifically, but I think there was a great emphasis in the rooms, which I'm very glad to hear, that really qualitative insights need to go hand in hand to understand what is happening. Another insight that was shared through various rooms actually was sort of the importance to engage the end user, engage the patient at a much earlier stage of the development in the process. I think that there's quite a lot of change theory that suggests that that by engaging your end users earlier, there's also a better opportunity for them to engage with the intervention, and that in itself may help reduce inequalities. There was a particular risk raised around that as well, that a new challenge for that is that you then need to manage the expectations that you might raise with end users that are engaging in that work. I think there's also an additional challenge, I guess, in how health inequalities impact particularly digital technology, where there might be sort of 2 layers of inequalities. One where there might be inequalities in who is actually using the digital technology, and then on top of that, there might be inequality in how that is impacting various patients. So it's very important to be mindful of both of those. Also, something what was noted was that some of the inequalities in particularly sort of vulnerable patient groups may stem from very important factors that are happening outside of the healthcare sector. So particularly if we're trying to improve metric development and data collection within healthcare, we might still not be able to address some of that because there can be sources underlying to that vulnerability to do with, for instance, housing or other services that might not be captured in the data. And it was suggested that maybe more guidance could be provided or best practice could be developed on sort of really how to reach out to some of those typically hard to reach communities. It was noted that there might be quite a lot of learning from sort of spread theory that we could use. So when we see sort of successful innovations innovations successful in reducing health inequality, that we can learn from spreading theory how to make the best out of that and spread those practices as well. One for the a more sort of data specific one, particularly sort of thinking about quantitative measures and the use of AI. I think some of the common metrics that are being used to think about health inequality is, for instance, a measure of deprivation, which is typically an area level statistic, similarly to whether people live in a rural and urban area. So some of those metrics don't really reflect the personal circumstances of individuals. So you need to be very careful in using that information, particularly in sort of algorithms and digital technology, making sure that we don't potentially exacerbate health inequalities by sort of wrongly assuming what patient circumstances are. And then finally, I think some groups discussed roles and responsibilities, and needing to be very clear whose responsibility it is to make sure that marginalized groups are included in the evaluation. And maybe these roles and responsibilities aren't always the same, but I think there's an expectation that at the beginning of an evaluation, it's very important to agree where those responsibilities lie, whether that's the commissioner of the evaluation, whether that's the evaluation team, whether that's the health service team that is improving that, implementing that change. Because I think too often at the moment, health inequality is quite often seen as an afterthought that's being added towards the end of a evaluation. Is like, oh, let's do some subgroups on the data we do have, rather than it's sort of being core to the evaluation. So I think to sum all of that up, I think today has really shown that there's a key role to play for evaluation in sort of informing policy and practice and support the NHS in responding to the aftermath of the pandemic. That's no surprise, obviously, because I'm an evaluator myself. So I'm not going to conclude today that is not important. But I think I think we can all agree that there's more to be done in the field of evaluation, and we can particularly look out for unintended consequences like increasing health inequalities in the changes that are being implemented. Given we all have an interest in evaluation, I would also like to point out to you that there will be an evaluation form with this conference, and I think a link will be provided in the chat just about right now. So I would very much appreciate it if you could take your time to fill that in, so we can also reflect on that for next year. And then what rest me to say is that I hope to see you all again tomorrow for the second day of the conference, where we'll be exploring the theme of sustainability. We will explore lessons from rapid evaluation of evolving and new services aimed at assessing the sustainability of health services. We'll also be discussing the research priority areas to inform policy and environmental sustainability. And hopefully we'll be able to show you some really good examples as well of sort of recent evaluations that are focused on achieving a green and sustainable system. So thank you all very much for attending today. And hopefully you can join me in thanking all the chairs and speakers we've had today as well. And I wish you a great afternoon and hope to see you all tomorrow. Thank you.